Good day, it's Dr. Daniel Cameron. I'm here with another video blog. I'm here to discuss an article that was published in the Clinical Infectious Diseases journal. In this case, the authors gave the impression that 2 weeks of antibiotics was good enough. But the title of this blog is called More Problems with a 2-Week Course of Antibiotics for Lyme Disease. So I'm going to show that 2 weeks is not near good enough for the patients that I take care of. The title of the article is called Course and Outcomes of Early European Lyme Borreliosis, also called Banworth Syndrome, Clinical and Laboratory Findings by Ogrinc. Now these authors are affiliated with the Department of Infectious Diseases in Slovenia. Complications of Lyme disease that we've been concerned with in the past include chronic neurologic Lyme disease, Lyme encephalopathy, post-Lyme disease, and post-treatment Lyme disease syndrome, or PTLDS. Legigian, Kaplan, and Steer in 1990 in the New England Journal of Medicine raised a concern. Quote, the likely reason for relapse is failure to eradicate the spirochete completely with a 2-week course of intravenous ceftriaxone therapy, unquote. In the 2016 recently published Ogrinc trial, there were problems with a 2-week course of antibiotics. The 77 patients that enrolled with this early European Lyme borreliosis included signs and symptoms such as radicular pain, sleep disturbance, erythema migrans, headache, fatigue, malaise, paresthesias, meningeal signs, peripheral facial palsy, and paresis. The first problem with the Ogrinc study is that they treated 77 patients, but antibiotic therapy had to be repeated within 3 to 6 months for 20 of the 77 patients, or a failure rate of 26%. The failure rate, if we break it up into details, were 3 with unsatisfactory clinical response to the first treatment, 8 with a persistent abnormal cerebral spinal fluid, and 9 with both an abnormal clinical response and an abnormal spinal tap. The second problem with the Ogrinc study after 2 weeks of antibiotics was that there was an unfavorable long-term poor outcome in 9 of the 74 patients, which is 12%. And this consisted of intense, annoying, nonspecific symptoms, persistent peripheral facial palsy, or remaining paresis that influence functioning. The third problem with the 2-week trial was these poor outcomes came despite relatively short durations of illness. The median duration of illness was 30 days. There was another study that was published this past year that showed problems with a 2-week course of intravenous ceftriaxone. This was published in the Netherlands, with Berende as the primary author. The quality of life in this Berende study from the Netherlands for 98 patients with persistent symptoms rose by only 3 points to 34.8 on a physical component summary score, which is a measure of quality of life. Their quality of life remained below that of cancer and heart attack patients and far below the wellness of a general healthy population. The third study I'd like to refer to was a study out of US Hopkins where they described post-treatment Lyme disease syndrome, symptomatology, and impact on life functioning. Is there something here? There were problems with the Johns Hopkins study published in 2013 that were similar to what we're seeing in Europe. At 6 months, 36% of 66 patients that were treated at the time of an erythema migrans rash with 3 weeks of doxycycline reported new onset fatigue, 20% had widespread pain, and 45% had neurocognitive difficulties. These patients were told they suffered from post-treatment Lyme disease syndrome, also called PTLDS. Patients who developed PTLDS had significantly lower life functioning compared to those without this condition. None of the patients described by Alcott were retreated as described in the Ogrinc study, which would be considered treatment failures. The message is, as doctors, we have to come up with better regimens than the 2 to 3 week course of antibiotics described in the Ogrinc, Netherlands, and Alcott study to avoid the treatment failures that we're seeing today.